Vaccine equity is something that the world neglected for a very long time, and began to pay more attention to in earnest about 20 years ago, driven largely by the Gates Foundation and the Children's Vaccine Initiative, and then most importantly, Gavi, which started just over 20 years ago. Gavi was an international enterprise dedicated to enhancing speed and breadth and depth of access to vaccines for children in poor countries. And since it was created, beginning with expanding access to the hepatitis B vaccine, I would say that Gavi has been one of the most successful ventures in global public health in history. It's really an extraordinary story of compressing the time between innovation and people who need vaccines most getting access to those vaccines. I mean, it's just so ironic that when you think about something like rotavirus, that the children in the countries where kids rarely die of rotavirus, like in the US or in countries in Europe, were the first ones to get the rotavirus vaccine, when in fact, the children who have the greatest likelihood of dying because they don't have access to a working health system were going to be the last ones to get access to that vaccine. And that was the premise upon which Gavi was established, to take a timeline that had been measured in decades between availability of vaccine and children in poor countries getting access to it, and shrink that down to something as close to a few years or even no gap at all. When I was at the Gates Foundation, then we spent a lot of time thinking about the many barriers to equitable access to vaccines. And when I joined the foundation to run, at that time, what was called the delivery team and quickly became the vaccine-focused delivery team, the vaccine delivery team, we had a strategy that was spearheaded by my predecessor, Gurin Bihari, that broke down the access challenges into 5 buckets, which I think for the sake of giving you a framework, I'll just recap here. One, and all of these things we felt were necessary in order to achieve access. And if you had everything working, but one of these things was missing, then you could fail in ensuring access. So the first dimension was having the right target product profile, meaning is the vaccine tailored for the population and the environment that you intend it for? Secondly, was the policy and regulatory environment. So you can have a vaccine in hand, but if it takes a very long time for a national regulatory authority to approve it, or for the World Health Organization to pre-qualify it, then that can be a major impediment to getting access to that vaccine. And similarly, if you have a licensed vaccine in a country, but then the recommending body, the expert body that tells governments whether they should or should not introduce a vaccine, takes a long time to gather the evidence or to make a decision, that can get in the way of a licensed vaccine actually making it into a routine immunization program, which is the best way to get a vaccine to all the children that need it. In the US, the group that does that is the ACIP, and we've heard a lot about the ACIP in the course of COVID. Every country around the world, most countries around the world have an ACIP equivalent called the National Technical Advisory Group on Immunization. That's the category, and then they'll localize the name of it. But basically, it's external experts telling the government what to do, or advising them. The third area was financing. So you can have a licensed and recommended vaccine, but if there isn't money to buy the vaccine, either at the government level or at the level of the family, then of course you're not going to have access. The fourth was delivery platforms. Platforms being all of the logistics and human resources and education and demand necessary to take up vaccines. And if you think about what's happened in COVID, we've had issues along that entire spectrum, including on the demand side. So you can have, like in the US, widespread access to vaccines, but if the public is skeptical about the safety or efficacy or need for getting a vaccine, then you're not going to achieve your goal of equitable access. And the final dimension was leadership of the health system. And that can be the actual health leadership, or in the case of COVID again, general political leadership. And where we've seen around the world gaps in either health or overall leadership in governments, you can see poor uptake of vaccines. So those different components we felt all needed to be in place in order to maximize the chances of achieving equitable access. And I would say that that's a great framework for peacetime equitable access to vaccine analyses or considerations. And hopefully that's a framework you can take into these discussions and your thinking, but you can actually apply that exact same framework to almost any intervention in public health. So I think it's a pretty useful one to keep in mind. It's about 12 or 13 years old at this point, but I think it's still applicable. Well, you know, in COVID, you have all those barriers that we started with, but then there was a whole new driver of inequity that many people recognized early in 2020, which is around availability or supply of vaccines. I had the opportunity to work with a handful of people to brainstorm ways to get ahead of what we expected to be massive inequities in vaccine access. And those discussions happened in the spring of 2020 because we expected, based on the H1N1 experience and also just knowing how the world works, that there was a high likelihood that the first vaccines to be proven safe and effective would go to the wealthiest countries in the world. And so that was a set of discussions that led to the creation of kovacs, which was an effort to pool financial resources to give, with a primary goal of giving low and low middle income countries a seat at the table with money in hand to negotiate supply agreements with companies early, and in the same time frame as wealthy governments would be doing that. It was also, importantly, a way of pooling risk, meaning that if you're a government with limited resources, you're not going to be in a position to go out and negotiate contracts with Pfizer and with Moderna and with Novavax and with AstraZeneca and J&J, because you don't know, because you'd have to do that actually as a government, not knowing in the summer of 2020 whether and which of those vaccines would be successful. COVAX was a way to say to governments, all you need to do is tell us how much vaccine you want. And what we will do is pool that risk. We will monitor the progress of vaccines in development. We'll place the bets, and we will deliver to you one or more vaccines that meet the minimum criteria that we agree your population deserves to have access to. That was the idea. Now, for a variety of reasons, that hasn't played out in full the way it was intended. Although it has had a lot of success, it certainly has fallen short of many people's expectations, and we can talk about that. But I think that it brought to light a new dimension around equitable access that we never had to consider before, which is whether there would be enough vaccine to go around. And in this case, by definition, when the entire world needs a vaccine, there is no way that you can have enough supply to reach everybody in real time. And that's an important additional consideration around equity. When we talk about equity, it's not about do you get a vaccine or don't you get a vaccine? It's about the timing of the arrival of that vaccine. If you have one group that gets access to a vaccine in late 2020, early 2021, and another group that doesn't get access to a vaccine until 2023, even though they get access to the vaccine, because there's a 1 year plus gap in timing, that's massive inequity that we're seeing in COVID. It also means having access to similarly efficacious and safe vaccines. So if one population gets access to a vaccine that's much more effective against disease and severe disease than another population, that's inequity. And so we need to think about equitable access across these multiple dimensions. It's not just about are you able to get a vaccine or not. So I think that this conversation is happening at a very, very interesting time, given what we've learned recently with COVID. I would encourage you in your discussions to not limit your focus, however, to what's happened in COVID, because that is a very special type of problem that we're dealing with in this moment in history. And ideally, the dialogue that you go into here will have more shelf life, to use another industry term. You want the insights that you gather in these discussions ideally to be applicable to peacetime access to vaccines and ideally access to any important public health intervention. So with that, Joe, I think I'll just stop. Hopefully that was useful as a conversation starter, and happy to have a back and forth with you all. Yeah, it's a really important question because as the movie played out, people in the fall of or December 2020, January, early 2021, were saying, wait a minute, why was kovacs designed the way it was? One of the design elements in kovacs was to, and by the way, kovacs was not intended to be just for low and low middle income countries. It was intended to be a place where any government, including self-paying governments, could come and use as a pooled procurement mechanism to get better terms on access to vaccine, better pricing, for example, and ideally would allow them to get as much vaccine as they wanted, probably with a premium placed on the vaccine in order to help fund the low middle income access to vaccines, so that wouldn't just be reliant upon donor support. One of the design principles of kovacs was this idea of getting everybody up to a certain level of coverage in their countries before allowing certain governments that were able to pay their own way to go beyond that. So if you're a government that's self-paying, you were going to be capped at 20% of your population until everybody got to, including all the low middle income countries, got to 20%, then you could get more. So that ended up being a source of frustration for some countries that didn't want to be capped, and they had their own public resources to be able to finance vaccines, and led many actually to go procure their vaccines through other channels. The flip side of it also came up, where a number of countries, including in the African region, came in and said, wait a minute, we weren't adequately consulted. I mean, this is what I've seen in the media. We weren't adequately consulted, and somebody decided that 20% was good enough for us. And we never had a say in that. Now, without getting into how this all came about, I think it's a fair comment and fair feedback. So that's definitely one area that needs to be re-examined as we think about what we're going to do prior to the next pandemic. Having said that, I don't think there's any easy answer to that problem, because the framework was actually created to address an equity issue, to ensure that all boats came up at the same time, at least with a 20% threshold. So that's one. I'm sure there are others we could talk about. Would be a luxury, I guess, for us to not have to worry about the national allocation and start to focus on subnational allocations of vaccine. In many issues, from a global perch, you have a hard time controlling what happens within the borders of a country. Every country has a sovereign right to do what it chooses with its resources. And in theory, the population put leaders in place to make decisions on their behalf on things like allocation. Now, you may find in a country that those political leaders allow things to happen that you wouldn't want to happen or would be handled differently in other places. But that's the whole point of national sovereignty, is that countries make those decisions. Now, Gavi is the executing arm of kovacs, and basically the entity that is the lead on kovacs, has created a window of funding for migratory populations, refugee populations, which I think is very important, because they're often forgotten, and they're often the most in need, per the rotavirus example I gave earlier. So I think there are some opportunities, conflict areas. You can think about ways to prioritize them over others. So there are examples of limited interventions at the global level targeting subnational groups, but it's specific. It's specific. It's hard to do that on a whole scale. And actually, I think this group being quite familiar with these issues probably knows, if you look at the population of people around the world who don't have access to, who have the worst access to health services, the majority of them are sitting in middle income countries, because there are some very big middle income countries that, I mean, huge populations. And so even though they're middle income at a GDP per capita level, the number of individuals that are not getting access to health services is quite large. And so so you kind of miss those populations when you're focusing just on national statistics, and there it becomes an issue of working closely with those governments to ensure that they're, to the extent possible, allocating their resources in a way that ensures the bottom of the pyramid, as has been called in the past, is getting appropriate access.